So then appointment of champions and a team. Is there a champion in place with time allocated for the champion to do the work? Is there a co-champion in place with time allocated? Is there an interdisciplinary team that meets regularly to discuss implementation and outcomes? And staff education. Has there been required staff education on Interact? And has there been required Interact overview and new staff orientation? Again, very important for this program to be sustainable, that you continue with every new staff member getting trained on Interact. Okay, so the next section underneath the top section is tracking and trending hospital transfer rates. Are all unplanned admissions tracked and also trended? So again, that's where that readmission tracking tool is so important. Are you also tracking your 30-day readmissions? Are you also tracking emergency room visits without admission? So any acute care transfers, are you tracking them and also trending them? And also observation stays. Then you have your quality improvement activities. Have you performed root cause analyses using the Interact Quality Improvement Tool or similar tool? Again, we here at Qualidigm really like the Interact Quality Improvement Tool. It's easy to use. It's a team effort. It's not just one person filling it out. And we believe that for any acute care transfer, a root cause analysis should be done to figure out, could something have been done to prevent this transfer. Do you summarize root cause analysis data and use results to focus on care process improvement and education? And in-person meetings with local hospitals and a cross-continuum team focused on reducing preventable hospital transfers. This is really important for those nursing homes that are part of a community. You should be using the quality improvement tool as you're doing your case reviews and also reporting out on any root cause analysis that your team has done and reporting on the outcome. Next, the next section is the tools. So you want to document, stop and watch. Are they implemented on all the units or just some of the units? The SBAR form and progress notes. Is it all units or some units? Changing condition vital cards and care passes are what we're going to be talking about today. Transfer forms or transfer data lists. Are they implemented at all units or some units? Nursing home capability list, the transfer document checklist, the MedRec worksheet, advanced care planning tracking form, and other advanced care planning tools. Are they on all units or just some units? And again, you need to be as honest as you can because this is really a work in progress sheet, and as I mentioned, should be looked at and updated every 6 months or so. So the next section is improved communication. Have you seen improved communication between the nursing staff? Have you seen improved communication between nursing staff and the medical care providers? So this is where you sit down with your medical director and also your other medical providers to talk about SBAR, to talk about the transfers form. Again, has there been an improved communication? And also with the hospital. Improved nursing evaluation. Have there been earlier identifications of acute care changes in condition? This is why you have Interact in your building, is to have a earlier identification of acute care change of condition in your residents. It's all about the residents. And do you have more comprehensive evaluation of acute care changes in the condition? And is there more structured and relevant progress notes now? Because Interact has been initiated into your daily life. So then we're going to be going back to data. And we're looking at all unplanned admissions. Have there been a reduction in all unplanned readmissions? Has there been a reduction in 30-day readmissions? Has there been a reduction of emergency room visits without admissions and also on off days? The second to the last section is improved quality improvement processes. Is there a better understanding of preventable transfers? Or have there been targeted educational activities based on root cause analyses? And has there been targeted care process changes based on root cause analyses? So again, from all those QI tools that you've used for those unplanned transfers, and then you've done those root cause analysis, what have you done with that data? What have you done with that information? Have you improved systems within your facility? Have you provided more education for your staff? And it's not just your nursing staff. It could be your, with the step and watch, everyone should be able to touch that tool if they have noticed a change in condition in a patient. And finally, has there been improved referral patterns with your nursing home? Finally, this is an open section for comments on implementation. This is where you can write notes to yourself, write notes to your team on what the next steps are going to be, what you plan on doing, the timeline for which you plan on doing the next steps. And this should be, again, available for each of your team meetings, but really put on the agenda for at least every 6 months to review and update as necessary. So does anybody have any questions? Can we open up the line real quick?
If you have a question, if you can press #6 to unmute your line. We do have a question in chat. Oh, about the phone number. Okay.
We'll sing some music. What are we going to start? So we're putting that phone number in. That's our So what is it, *6 to ask a question about the implementation checklist?
Yes.
#6. Again, this is one of the requirements in order to get your participation certificate at the end of the session, and it has to be signed by your nursing home administrator. You can always save your question till the end also. Sheila's anxious to get started. So with that being said, just want to let you know if you are still would like to listen to the past session, this is how to get onto the New England QIN-QIO website. You click on events, you scroll down to previous events, click on months to find the session you missed, and then you click on the webinar recording link. And we do track this on a monthly basis, so we will capture whether you listened or not. These are the Interact session dates that we've already had. These are the 7 that we've had already, and today is number 8. With that being said,
everyone, this is Florence. I just want to put a plug in for your QAPI. So as you meet as a group and you address any issues at all, remember that you can now take those documents that you're keeping notes on to help you with your PIP and developing your QAPI plan based on whatever you're working on.
Thank you, Florence. Thank you, Florence. Thank you, Caroline. I was anxious for Florence to make that statement, how all these projects sort of roll together, which I think is a relief for busy staff that you're not being asked to do different things, but maybe the same thing, and use it in different ways. So, as Carol went through the implementation checklist, again, we realized that the heart and soul of Interact is change in resident condition. We want to be able to recognize it, respond to it, communicate it effectively within our facility and to providers during handovers of patients. So the two backbones of change in resident condition are the decision support tools of Interact, the acute change in condition file cards, and the care paths. And these have been designed with evidence-based best practices to provide staff with information on how to respond to change in resident conditions. Button. Up top. Looking for a button there. All right. So the acute change in condition file cards, I'd really encourage you, if you haven't used these, at the end of this session, to just get on the web and download these and show them to your staff, because I think they will be very well received for a variety of reasons. Probably the first one is that it doesn't involve the staff having to fill out anything, which is always a relief when we present Interact tools. But the second reason is that they're concise and really easy to use. So the change in condition file cards are just pieces of paper that you can cut and you can laminate, you can put on a ring at the nurse's station, you can put in a binder at the nurse's station, and they quickly give you references for normal lab values, normal vital signs. That's the first thing you'll see there. And then alphabetically, they'll go through signs and symptoms. So, starting with behavioral symptoms and ending with, what do they end with? Vomiting. So there you go, just about everything. Easy to use, easy to access, and they become the first sort of decision map for clinicians as to whether or not an MD or an APRN need to be called emergently, and the patient needs to be evaluated in real time, or whether or not whatever the symptom is can wait till the next time an MD or APRN are rounding. So let me give you an example. Diarrhea, something we see a lot, right? Immediate notification is recommended if you have an acute onset of 3 or more episodes of loose stools. It can wait till the next MD APRN round if it's multiple loose stools with stable vital signs. So this is handy. This becomes a great tool for new staff, for new orientation. And it's kind of a package for you to you can take these file cards and you can take these care paths and you can make them your policy and procedure concisely. You can show these to staff as this is what we do, this is how we deal with these things in this facility. They're evidence-based practice. They'll stand up against any criticism in terms of how the changing condition was responded to by, in a medical legal sense. You're just doing the right thing. Now, that said, you can have these in a binder and you can put them in the nurse's station, but if they aren't integrated into practice, if people aren't using them, if people haven't been trained to use them, if clinicians and supervisors don't kind of check back with staff, I call the supervisor and I say, oh yeah, my patient is having diarrhea. I want the supervisor to say, well, is it an immediate problem or is it something that could wait till tomorrow? We want them to refer to the acute change in condition care cards to make that decision and not just clinical experience. I mean, clinical experience is something we all rely heavily on. I've seen this before. I hear people say that all the time. I've seen this before, and this is how I respond. I used to work with a great doc who was very committed to quality, and he would describe clinical experience as doing the wrong thing over and over again with increasing confidence. So if I'm going to say, I've seen this before and this is what I did, and there's not really evidence or science to back that, maybe it's working or maybe we're just getting lucky. So we want our staff to believe that there is a best way to do things. It's important to rely on your clinical experience and your gut, but there are the right ways to address changing conditions, and these things are at their fingertips. So we want to make that part of the culture. So So recommend placing them at the nurse's station, not to gather dust, but to be referred to. Recommend having them part of orientation, maybe reviewing them periodically in staff development. All right, so that's something about acute change in condition condition cards, and they really are handy. They're quick. They increase the confidence, I think, of new staff, and especially new grads, because rather than having to kind of keep something in your head and make these decisions again based on prior experience, here's the right way to do it. Here's some really concrete guidance. The second tool, decision tool, that Interact gives us is care paths. So care paths are really decision trees. They provide guidance on the recognition, evaluation, and management of 10 common conditions that lead to transfers. Again, I would really encourage you to print these out at the end of this webinar and pass them out, and everyone will say, oh my gosh, I see one of these every day. So however they gathered, the information on what to produce a care path on definitely had to do with people who work with long-term care, because they're going to seem very, very familiar to you. Yes, sir.
One of our facilities, our more mature facility that's been doing Interact and actually living Interact, what they did was to have their medical director look at all the care paths, agree to the guidance that it's providing, and he signed off on it. So now it became sort of like their own standing order. And the physician actually was surprised a month later that he wasn't getting called as often as he was before, and the director of nursing had to remind him that you gave us orders like signing off on the care path. So you may consider doing that, bringing it to your medical director's meeting and review it as a team.
Great point, Florence. And to do maybe 2 or 3 of them at a time and implement them. Again, kind of doing those short cycles of change that we talked about earlier. We call them plan, do, study, act. Implement the care path on one unit, see how it goes, check out how it was received, check out the results, and then roll it out to other units as you tweak it. Always a good way to implement it. So, care paths, again, they provide decision trees for the implementation of evidence-based best practice. Now, these are tried and true things that you can count on. Very helpful, again, for new graduates and the orientation of new staff. So here's one. It's a bit of an eye test, but I'm just going to run through it quickly. Mental status change, that's something that we see at least 3 times on the weekend, right? So, again, I chose this one to use as an example because this is one where you see a lot of people relying back on their clinical experience. Oh, I've seen that before. I think she has a urinary tract infection. I've seen that before. I think it's a reaction to the meds. So let's kind of walk through how you'd respond to it. You're looking at the change noted, and then you take vital signs. Before you do anything else, you take vital signs. And remember, thinking back to the S-bar and what goes on the S-bar, the care path to mirror that thinking process. So if you, as a clinician, walk through the care path, you're going to have all the information you need for an S-bar or an acute transfer if that becomes necessary. Right on the care path, you're going to see some vital sign criteria. Temperature over 100.5, what you look for in blood pressure, oxygen. If none of those criteria are met, you go to the next level of assessment, assessing whether or not the patient's eating or drinking. Is there a new cough, nausea and vomiting, worsen incontinence, doing a pain assessment. If any of those things exist, you would notify an MD or a PA or an APRN. Then, if they don't, the clinician, the nurse on the floor can consider asking for further testing in the form of a chest x-ray, urinalysis, blood work. Order the tests, and again, right here on the care path, it's going to have the results that are either indicative of the need for more aggressive treatment or not. And at the very end is our favorite part, management in the facility. talking about what to do next. So in this case, with symptoms of acute mental status change, we talk about continuing to monitor vital signs, oral IV fluids, checking results of tests, pain management, non-pharmacological interventions for delirium. So these are going to help us in a lot of different ways. As I said before, it gives a clinician some evidence-based practices. It also gives us something to walk through with families. So when a family member comes up to us and says, Auntie M looks so confused and she gets like this when she has a urinary tract infection, we can turn around and say, well, that might be it, but let's look at all the symptoms. Let's really look at Auntie M's vital signs and maybe do some lab work or assess her for pain or other things. So it becomes a way for us to let families know that we're not ignoring symptoms, we're evaluating them and not reacting with the highest level of intervention early on. All right, so again, I really, encourage you to use these care paths, to download them if you don't. But before I go any further, is anyone out there using them? We have a polling question.
Emily or Jennifer, can you open the polling question, please?
Okay. So is anyone using care paths either by Interact or maybe within your own policy and procedure manuals? Give you a few minutes to, don't forget to hit submit. Okay. That didn't seem to register, so.
Yeah, it'll be up in a second. There were probably a few people that selected their answer but forgot to submit, so it's waiting for some people to hit that final submit button.
It's waiting for you.
But it will pop up in just a few seconds.
Again, if you're in a cycle where you're...
Here you go.
Perfect, thanks. Okay, yeah, that sounds good. Very good, and I hope the people who are using care paths, when we get to the discussion part of this webinar, can talk a little bit about how you implemented them and how you got people to use them. If you're in a cycle at your facility where you're considering reviewing and redoing policies and procedures, here they are sort of laid out and ready for you. So that's really good. And I would be interested to hear how folks have managed to implement these, got their medical directors and APRNs and MDs on board with them, and how the staff likes them, of course. We're always looking for that feedback. So thank you for that. So thank you for your time. I'm going to turn this back over to Carol.
Florence, did you have anything you wanted to add?
No, you two ladies did a great job.
Oh, dear. Okay, so let's review the homework from last month. So from our last session, we talked about the advanced care planning tools and the communication guide from the Interact website. And you were supposed to make copies of the tool for the team to review. The team leader was also supposed to download these tools to a facility computer on a shared drive, so you will always have them available. Also, the homework from last session, the team was to review together the advanced planning tools and communication guide. You were to discuss how and when the staff nurses, social workers, supervisors, leadership, and medical director will be educated on the use of these tools, and decide which unit will begin to use the tools. Remember, you always start small, use the tool a couple of times and then you do a PDSA cycle, plan, do, act, study, and tweak it a little. Each time you tweak, it gets better and better. And as it gets to a point where you say this is the best it can be, then you start spreading that tool. The team was supposed to develop a timeline to define when the education will occur. and when the tools will be first implemented. And as always, whenever you begin a new process, you start using a new tool, the first time you use it, you always debrief with the team. How did it go? That's your PDSA cycle. What could we have done better? What should we have done? And how should we move forward with this? And that's what we mean by a debrief. And then finally, as with any time you meet with your team when you're talking about Interact and readmissions, you should always be looking at your data and looking at your data entry, the system of data entry. Are there any issues, any glitches, and making sure that you are looking at the data. So with that being said, we would like to open up the lines, and you know Florence, she's going to be calling people out. We'd like, as Sheila mentioned, we really would like the facilities who have implemented this to share what's been working, what hasn't been working, related to the advanced care planning. Have you talked with your leadership and your medical director about tool implementation? How did that go? And how about the first time you started using the tools? How did it go?
And we'd also like to hear from those of you who haven't started using it, what the barrier is, and if there's anything that we can brainstorm together to help you get started to at least do that first try.
Okay, so it's #6. Don't listen to me. It's #6, not *6. So open up your lines, and we're looking at the names right now. So Florence is going to be good for you. So come on, folks. How did the advanced care planning implementation, how is it going? Or what are the barriers?
Or if you already had a process before you started with Interact, tell us about your process and how it works. When do you talk to patients, residents, and their families about advanced care directives and specific orders like do not hospital, do not transport? What process do you have?
Hi, Giovanna. Can you open up your line? Pound 6.
Can you hear me?
Yes.
Yeah?
Is this Giovanna? Nope, we can't hear you now. Pound 6.
Can you hear?
Okay, I'm going to move to Marley. Can you open up the line? Marley.
Pound 6.
All right, Michelle Ackerman, are you on the line?
Up here. Okay.
How are you?
I am well. How are you?
Good, thank you. Have you, we were wondering maybe we did something to the phone line over here.
Or to offend the group.
So have you attempted to use the advanced care planning tools at all?
We actually were chosen by the Department of Public Health to work on the MOLST project, so we're part of that pilot project, and we're rolling that out.
Okay.
So we have already instituted, for a while now, we've had comfort measure only orders and goals for talking with families about goals of care. And so when families are not really ready to talk hospice, we have met with families and practitioners and the whole team with the residents to find out what really are their goals of care and ensure that we're very explicit in what they want done or not done, do not transfer out of the building, what kind of care planning interventions they would like at end of life if they're not looking towards a hospice benefit. So we've been focusing on that, and now we'll be focusing on the MOLST project.
Great, awesome. You guys are doing a lot over there.
Yeah.
Okay, well, thank you for talking to us. I was going to say.
Oh, you're so welcome.
Okay, thank you. Anybody else wants to jump in? Miss Veronica Miller, pound 6 to open up your line.
Florence.
How are you?
Good. You know, it was funny. I was just going to unmute and talk anyways. And then you called me.
We were on the same wavelength.
We actually started last year reviewing upon admission, and every quarter the MDS department is involved. So they review a packet of information with the patient and the family, which just explains what advanced directives are, goes into detail about the stages, and they usually will go over diagnosis. Sometimes the patients come from the hospital with already a semi-terminal diagnosis or that advance in dementia, so they're having that discussion. We've actually changed quite a few residents, their advanced directives over to more of a comfort care, staying upon their quarterly meetings. And our head nurses do an excellent job, so when they see any changes of condition, when we review our weights, when they look at that weight loss, and they also have, it's mostly with that advanced dementia, we're discussing and doing changes with their advanced directives with that. We've been also working with Dr. Hinton through St. Vincent's, and the programs, looking into the MOST program with also Griffin Hospital. So we've been working with Griffin Hospital, and we're going to start implementing that process.
That's awesome. Thank you so much.
Oh, you're welcome.
Hi, it's Sheila. When you talk to people about advancing dementia, I think that's so important. That's so powerful because dementia is such a unique disease, and as much as it's hard to tell when people are getting worse and nearing the end of life, has that been your experience? Do you feel that families can understand not the chronicity, I guess, when people with dementia are kind of crossing that line between being stable and very sick to being, towards the end of their life? How do you describe that? I'm just curious. How do you help people understand that?
Veronica, I think that's
or anyone, actually. Someone help me understand it. I know we talked about weight loss and, the inability to perform ADLs, but some people with dementia have been like that a long time.
Yeah.
So I think I guess no one has to respond. It's just, I just see that as such a challenge in long-term care when people have dementia and might have had it for 2 years, and families have been committed to their care, and people getting excellent care, and people getting full care. It's really a journey to move over to the other side. I think we're getting better at it, I guess. I hope we are.
All right. Anyone else need? Oh, go ahead. Sorry.
No, that's okay. No, I just wanted to, hello, finally. I think our resistance here is, just cultural with people making that decision to do not hospitalize and DNR. They are just very committed to everything possible to sustain the life here. And, it's tough. Even though we're educating, it's just they just don't want to make that decision to not have those things happen. It's just really, so many times we're sending people to the hospital and it's family insistence when we have everything in place to do and keep them safely here. It's just family insistence many times.
How's your medical staff helping you with that? Your APRNs, your PAs, even the medical director?
Sure. Our PA does have a bit of an accent, which I think hinders some of those folks that we're having difficulty understanding the process. We do have a Spanish-speaking social worker, which helps. We have an Optum APRN that is
also trying very hard to, I don't want to say convince, but explain. Yeah, educate. And it's really tough. It's just not easy. It's just very challenging. Whether the family assistance can be looked at as not a facility defeat, but as just as a way of understanding that even though we're trying, the family is insisting they still have those choices.
And not to make everything boil down to dollars and cents, but at the end of it, it does boil down to dollars and cents. With the new 5-star rating and the new rulings that CMS is sending us, sending a resident to the ER on family's request is no longer going to be acceptable. So, I don't know if you need us to come out to your building and have a discussion with your family council if you have one, your resident council, but if you need any support from us, let us know, because times are changing and we need to really change how we're doing business.
As we did reach out to the palliative care team at our local hospital, and when we see these patients going to the hospital, they are going to make contact with them in the emergency room and complement our conversation. So maybe that will help.
Absolutely. And remember, all of the Interact tools are kind of designed to help us treat patients whenever possible in place. So if a family says, we need to go to the emergency room, you can even go back to the care path and say, these are some of the things that we do before we take someone to the emergency room. Just like if you were home, you'd call the doctor and the doctor would say, well, take his temperature and give him some orange juice or whatever. This is the way we do this. We're not just standing in your way and being lazy, but this is the way we proceed in a thoughtful manner. So rely on those care paths. Yeah. Rely on those evidence-based tools to guide you. But I guess I'm sensitive to this because I'm having this experience in my personal life where a family member's in the intensive care unit and very sick, and I guess every time you experience this, you look at it with such fresh eyes. The family's still saying, well, yesterday you said you could get better. Yesterday, you did another test. Yesterday you called in a specialist, and it's so hard for families to understand when we, as clinicians in our minds, have crossed that line and said, okay, we're moving away from treating and helping someone to kind of torturing them and making them uncomfortable. So, yeah, I'm interested in how you have those discussions and how it's going for you.
Thank you.
Thank you.
Thanks.
Anyone else wants to volunteer? I think you guys like me picking on you. That's why you're not volunteering. Okay, Richard Bates. Pound 6. Richard Bates, open your line, pound 6. All right, while we're waiting for Richard to figure out how to open his line, how about you, Olga? Pound 6.
Tell us how you have those discussions. It's so important. It's such an important thing to share.
I think these are the people who signed on and walked away from their homes. Possibly your principal. All right, I'm going to try one more person. How about Michael? Oh, who's there?
Oh, hi, it's Jack Kelly. I don't know if you called me.
Hey, Jack.
Yeah, one of the experiences that we have, because we do it all the time, obviously. It's hard because families sometimes just don't want to look good. And we had a gentleman that was respiratory compromised. He was utilizing his Medicare benefit. We were doing everything there. And even at this point in time when his 100 days were up and he's still respiratory compromised, we had the hospice consult and everything, but the family, the funds they're just not there. Even though they know that they don't want really anything done as far as providing comfort measures. And then at the last moment when we have to call the family, even though it might be comfort measures, they change their mind and say, no, ship them. I want to go into the hospital. And that's hard because when you're talking about, a lot of times you can come up on an off shift and it's your 3 to 11 soup or your 11 to 7 soup. It's a hard conversation, with the family. And when they say, I want them shipped, because then it's time of the essence at that point in time. And they're not really receptive to change their mind again. But I had a person that was on hospice and the family wanted something done and we had to take them off hospice to do it. They are difficult conversations. And I too am the same as Claire mentioned about having a personal experience. So it's difficult.
It is.
Oh, thank you for sharing that. And that's another good time to do a debrief after those kind of transfers do occur for the team, the nursing team, just to meet for a short time to see how everybody's doing, checking in to make sure everybody's okay, because transferring to the ER was not the right thing to do, but yet the family insists. So you gotta do it, but you also just want to check in to make sure everybody's okay, and hopefully once that resident comes back, you can start having a stronger or better conversation with the family. Or continued conversation with the family. It is a really hard place to be. So thank you so much for sharing. Okay, so for homework for next month, you need to review the acute care change and condition file cards with the implementation team. Decide on where you're going to be putting them at the nurses station for both the file cards and the pathways. And then you also want to develop an implementation plan for the staff education. Not done yet. You want to review the Interact implementation checklist that I went into great detail over this afternoon. And you want to sit down with your administrator. First, you want to sit down with your team and have a good sense of how the team is feeling about the implementation checklist, and then invite your administrator in so then you can have a full discussion with him or her. And again, it's not just about the tools, it's about incorporating the entire quality improvement program into your everyday work life. If you find a gap in any of the areas of the implementation checklist, you want to do a root cause analysis as to why the implementation of the tool or process hasn't taken place. And on November 30th, which is our last session together, we are going to be we are going to be calling out a lot of folks to say, how did this go? And let's talk about what your findings were on the implementation checklist. Because this is a huge endeavor. We didn't do it last time, in the last session, and the internal team, as we talked about it, this is really an important, powerful tool to sustain the Interact program and also to move it forward.
Yeah, I was just going to say, in that discussion, we need to have them talk about their sustainability plan and how you plan on moving forward.
So with that, before we close out, does anyone have any questions for any one of us? Sheila, myself, or Florence? Again, #6 to open up your line. We're here to help. And here is our contact information, especially for those who need that readmission tracking tool that if you're not in Advancing Excellence, which, again, we highly recommend because there's so many good tools in that, so many good reports that you can pull from your data, or if you're using the Interact readmission tracking tool, or if you have a corporate readmission tool, you can just copy and send it to us, whether you can fax it to us or email it to us. We only want facility-level data. We do not want patient-level data. Or the tool that I shared with you earlier this afternoon, we can also send to that. With that being said, since no one's opening up their line, I'm going to turn this over to Morgan. She has a couple more points to talk about.
Thank you, everyone. As you close out of this webinar, the evaluation will automatically pop up on your computer. If you could fill that out, we'd greatly appreciate it. If you don't have time to do it today or you're sharing a computer with somebody else, you will receive an email tomorrow with a link to that evaluation. In that email will also be a link to the event page, which contains the PowerPoint presentation, and within a few business days will also include a transcript and recording for this session. Obviously, be on the lookout for emails about our next webinar, our next and final webinar on September 30th. Thank you for bearing with us for some of our technical challenges today, and we look forward to seeing you guys again next month. Thanks, everyone.
Bye, everyone. Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.